The fan and steel incision is commonly used for abdominal entry. The incision follows longer lines of skin tension, and thus excellent cosmetic results can be achieved. It also offers decreased rates of postoperative pain, of fascial wound dehiscence, and of incisional hernia. However, the fan and steel incision is often discouraged for cases in which a large operating space is essential or in which access to the upper abdomen may be required. Two to 3 centimeters above the symphysis pubis, an 8 to 10 centimeter transverse incision is made, and its lateral margins are curved cephalad. The skin incision is made sharply with scalpel and then extended deeply with the electrosurgical blade until the anterior rectus sheath is reached. The superficial epigastric vessels can usually be identified halfway between the skin and rectus fascia, several centimeters from the midline. If lacerated, these may be coagulated with an electrosurgical blade. In this transection view of the lower abdomen, the incision reaches the rectus sheath. Once again, bleeding subcutaneous vessels should be coagulated. The anterior rectus sheath is then incised transversely in the midline. At this level, the anterior abdominal fascia is typically composed of two visible layers, the aponeuroses from the external oblique muscle and a fused layer containing aponeuroses of the internal oblique and transversus abdominis muscles. Ideally, the two layers are individually incised during lateral extension of the fascial incision. The inferior epigastric vessels typically lie outside the lateral border of the rectus abdominis muscle and beneath the fused aponeuroses of the internal oblique and transversus abdominis. Thus, extension of the fascial incision further laterally may cut these vessels. Therefore, if lateral extension is required, these vessels should be identified and cauterized or ligated to prevent bleeding and vessel retraction if lacerated. In the area superior to the initial incision, the anterior rectus sheath is bluntly or sharply separated from the underlying rectus muscle. The fascia separates easily from the bellies of the rectus muscle, but may be densely adhered along the midline. Several smaller perforating vessels and nerves traverse this space. Coagulation of these vessels, while avoiding injury to the nerve, should be performed during the separation. With completed dissection, a semicircular area with a radius of approximately 6 to 8 centimeters is created. A similar separation is performed in the area inferior to the initial incision. The rectus abdominis muscle bellies are then separated along the midline either bluntly or sharply. The pyramidalis muscles, located superficial to the rectus abdominis muscle, usually require sharp division at the midline. The rectus abdominis and pyramidalis muscles are separated to reveal the peritoneum beneath. The thin, filmy peritoneum is grasped with two hemostats and sharply incised. This peritoneal incision is then extended superiorly and inferiorly. At completion of the intra-abdominal portion of surgery, incision closure begins. Reapproximation of the visceral or parietal peritoneum is not encouraged, as it closes naturally within 1 to 2 days. The fascial incision is closed in a running suture using zero-gauge delayed absorbable suture. In those patients with a subcutaneous layer greater than 2 centimeters, closure of this layer can decrease rates of wound infection and dehiscence. The skin may be closed with subcuticular suturing or staples. For operative vaginal delivery, several types of forceps are available. Each consists of 2 crossing branches. A branch contains 4 main elements: the blade, shank, lock, and handle. Additionally, each blade has 2 curves. The cephalic curve conforms to the round fetal head. The pelvic curve corresponds to the axis of the birth canal. After positioning, the branches are articulated at the lock in a tongue-in-groove fashion. Forceps may be used during second-stage labor if the cervix is fully dilated, membranes are ruptured, the fetal head is at a +2 station or lower, adequate anesthesia is present, the bladder is empty, cephalopelvic disproportion is not suspected, and position of fetal sutures is known. Commonly, forceps are used for a non-reassuring fetal heart rate to speed delivery. Alternatively, forceps may be used to compensate for maternal exhaustion or poor pushing efforts. When the fetus is in an occiput anterior position, the operator's right hand is placed between the fetal head and maternal left vaginal sidewall. The handle of the left branch is grasped between the thumb and 2 fingers of the left hand. The inner curve of the first blade is placed against the fetal skull. The tip of the blade is then gently passed into the vagina between the fetal head and operator's hand. The blade is swept upward and inward around the baby's head. With repositioning, the blade is adjusted with fingers up or down, and the operator's hand is removed. The upper edge of the blade should lie 1 finger breadth from the lambdoid suture. Once in position, an assistant can hold and steady the handle while the second blade is placed. The second blade is inserted similarly. The operator's left hand is placed into the vagina and alongside the fetal head. The blade is swept in, up, and around the head. After positioning, the branches are articulated. Gentle intermittent horizontal traction is then exerted until the perineum begins to bulge. Traction should be intermittent and applied with each uterine contraction. With traction, as the vulva is distended, an episiotomy, either midline or mediolateral, may be performed if indicated. As the occiput clears the symphysis, the handles are gradually elevated, eventually pointing almost directly upward as the parietal bones emerge. As the handles are raised, the neck is extended. After the head emerges, the forceps may be removed. Delivery is then completed by maternal pushing or by the modified Ritkin maneuver. Forceps used for cesarean delivery consist of 2 crossing branches. A branch contains 4 main elements: the blade, shank, lock, and handle. Additionally, forceps have a cephalic curve to conform to the round fetal head. At the time of cesarean delivery, the surgeon places her hand into the uterine cavity to deliver the fetal head. If extremely rounded and floating well above the incision, C-section forceps may be indicated. The fetal head is grasped, the head is rotated to orient the sagittal suture parallel to the uterine incision, and the posterior fontanelle is identified. For blade placement, the surgeon's hand is placed between the fetal head and posterior uterine wall. The forceps blade sweeps inward and curves around the fetal head. As with vaginal forceps, the upper margin of the blade should lie 1 finger breadth from the lambdoid suture. Next, the surgeon places her other hand between the fetal head and anterior uterine wall. Similarly, the forceps blade is slipped inward and around the head. With the blade positioned correctly, the forceps are articulated in a tongue-in-groove fashion at the forceps lock. When correctly positioned, the forceps blades lie across the fetal temple and cheek. Traction is then directed upward and outward through the uterine incision. Once the head is delivered, the forceps blades are removed and the body of the infant is delivered.